Good morning. Welcome to this CMF webinar. The COVID outbreak, as everybody knows now, has caused a lot of disruptions in our ability to get together and to congregate and to, in particular for AOCMF, do our trauma courses. And in light of the fact that we're having this difficulty getting together, the CMF Educational Board has decided to weekly start offering some of the content that we provide in our typical courses. And so we appreciate everybody logging on today to participate in this course. Our intention is that for the next 6 to 8 weeks on Wednesdays at this time to offer different topics. Today we are going to start with just our surgical approaches, discussions of the midface and also of the mandible. In weeks to come, we have scheduled pediatric trauma, orbital trauma, technology and reconstruction, minimally invasive surgical techniques, among others. So we appreciate again you logging in today. I'm Larry Cunningham. And also online with me as panelists are Dr. Raul Seth and Dr. Stephen MacLeod. I will be reviewing approaches to the midface, and Dr. MacLeod will be reviewing approaches to the mandible. Dr. Seth is going to be participating as a panelist, and in particular manning the question and answer window for us. For those of you who are unfamiliar, there should be a button at the bottom of your screen that says Q&A, and if you type into there, Dr. Seth will be reviewing those questions and relaying those to Dr. MacLeod and to myself. Let's see, I'm trying to make sure I've given all of my announcements, my pre-operative announcements, so to speak. One other thing is that we will be recording the session today, and the recording will be made available to everybody who participated after the event. So without further ado, let me go ahead and share my screen. These Zoom meetings are new to all of us, but we're trying to get it going here. So let's see. So I'll go ahead and start with the surgical approaches to the midface. Again, I'm Larry Cunningham, and I am Professor and Chair for the Department of Oral and Maxillofacial Surgery at the University of Pittsburgh School of Dental Medicine. Our lecture objectives today are to describe different surgical approaches to the midface for trauma and reconstruction, and we'll identify important anatomical structures and landmarks, and then go through a quick case. Our objectives when we are doing surgery are to identify incisions and exposure that allow us to put plates like this on the facial bones without leaving scars that are deforming or disfiguring or very obvious. And so the incisions that we advocate are those that tend to be able to be hidden relatively well. If there are existing lacerations, we will obviously tend to use those as much as we can because there's already going to be a scar in that area. For times when we don't have existing lacerations, the coronal incision, upper or lower eyelid incisions for orbital reconstruction, and then the vestibular incision or the upper buccal sulcus incision give us wide access to the orbital rim, to the maxilla, and to the arch without being terribly conspicuous. So we'll start by just reviewing the coronal incision as our access to the upper and middle third. depending on your training and the amount of trauma and other services that you may be involved with in the operating room, the head may or may not be shaved for the coronal incision. A shaved head certainly gives a cleaner plane for the surgeon, but also leaves the patient bald at least for a period of time. If your patient is like me, you don't have to shave anything, but the scar will be a little bit more conspicuous. But having that scar sort of at the mid-crown or even a little bit more posterior can hide that scar a little bit better. There are a number of different ways that people have described doing a coronal incision. Again, near the vertex of the head is a typical area that we keep that scar. This W-shaped or zigzag scar tends to help hide the scar better, particularly in the hair-bearing area where you don't have one widened line straight across and very visible. Alternatively, just a single unzigzagged or straight incision is very typical of this approach. Frequently for zygomatic arches, there is the need to extend the coronal incision down into a preauricular incision to be able to get to the root of the zygoma, to be able to plate the zygomatic arch to ensure anterior projection of the malar eminence. That extension of the coronal incision can be made here in front of the ear as is shown, or can be made even behind the ear. That incision can be made halfway or all the way down in front of the ear, depending on how much access is needed. There are a couple of ways that the incision through the pericranium can be, or several positions in which it can be made. Very typically, if we are approaching the frontal bar or the orbital rims for plating, we can elevate the coronal flap in the subgaleal plane, leaving the pericranium attached to bone up until you get to the frontal bone area, and then incise periosteum 2 to 2.5 centimeters above the supraorbital rim. That allows for ease of dissection, speed of dissection, and then the dissection of the periosteum over the rims is quicker in this area. There are times during facial trauma, particularly with frontal sinus injuries, that a vascularized pericranial flap may be of use to wall off the frontonasal communications. And when that's the case, the complete subgaleal dissection can be taken down to the supraorbital rims, and then the incision into the pericranium can follow the original dissection of the scalp, and allowing the surgeon to have a large surface area of pericranium to use for reconstruction or for separation of the nose and the frontal sinus. Some important landmarks when we are discussing this lateral extension of the coronal flap include primarily the position of the facial nerve branches. And we'll remember that those facial nerve branches lie in the superficial layer of the deep temporal fascia. And so on the diagram here, we see the temporal branch of the facial nerve, and this red line here, deep to this facial nerve branch, is where we want to stay as far as our plane, so that we protect that facial nerve. The picture on your right-hand side illustrates the dissection of in the subgaleal plane, the elevation of a pericranial flap that is sectioned at the temporal crest, and an incision superior to the temporal branch of the facial nerve, and then elevation of that flap beneath the superficial layer of the deep temporal fascia, so that we protect that nerve and then extend our incision to be able to access the zygomatic arch. Another important landmark is the temporal fat pad, so that we know that after this incision through fascia, when we are in the plane of the fat pad, the nerve should be superficial to our plane of dissection and thus protected during the surgery. While the dissection gives us grand exposure to the arch and to the lateral orbital rim and to the supraorbital rim, we know that one of the major tenets of our surgeries is the closure and of the suspension or resuspension of our soft tissue dissections. Because of that, it's important to reattach the fascia and to reattach the temporalis muscle if it was dissected up. A resuspension of fat pads into their previous positions, also very important. And depending on the depth and the level of the dissection, superior to inferiorly, resuspension of the buccal fat pad also would be important to prevent sagging and aging of the upper third and the middle third after a large traumatic injury and the surgery to repair it. Following the coronal incision, the next incisions for the midface are to approach the supraorbital rim or the lateral orbital rims. Here we have an illustration of two of the upper eyelid incisions that allow exposure of the ZF suture, the lateral orbital wall, and to the lateral canthus. The illustrations show a tarsorrhaphy for protection of the globe, and then two different incisions, one being a lateral brow incision and one being a blepharoplasty incision. The photograph in the middle has two different lines drawn with a blepharoplasty incision actually being created. The higher of the two incisions, labeled incision A or a brow incision, allow direct access to the rim, but less direct access to the lateral orbital wall. Whereas the blepharoplasty incision, incision B, with a 1 centimeter extension past the lateral canthus, can give a much wider ability to reach the area of the lateral orbital rim and the lateral orbital wall. I'm looking over at the chat and noting that Dr. Seth is scribing for us. So thanks Dr. Seth. Following the upper eyelid incisions, we discussed lower eyelid incisions, addressing the infraorbital rim, a little bit of the lateral orbital rim, and in particularly the orbital floor, as is illustrated in the green shading on the right-hand side of your screen. The illustration on the left-hand side of the screen reviews external facial incisions that have been described. The facial incisions are infraorbital rim incision, a mid-lid incision, and a infra-eyelid incision, all giving a very good access to the orbital rim. The photograph in the middle, again, showing the tarsorrhaphy and this lower eyelid incision approaching the orbital rim. The lower eyelid dissection, all of these incisions allow the surgeon to stay in a pre-septal dissection in order to prevent herniation of infraorbital fat, which is can be a benefit for exposure and for visualization of orbital floor fractures, and also can reduce the scarring of the orbital septum. And again, you can see subciliary, midlid, and an infraorbital rim incision here in the sagittal plane. An alternative to transcutaneous incisions is the transconjunctival incision, otherwise known as the transconj. There are a medial and a lateral extension of the transconjunctival incision that are illustrated on the diagram on your left side of your screen. The traditional transconjunctival incision is the middle part of this red line. That can be extended into a medial or caruncular incision, as well as a lateral canthal incision for greater access to the medial wall and to the lateral orbital rim, respectively. Again, the photograph in the middle showing the transconjunctival incision and access to the orbital rim and the orbital floor. And the diagram on the right side is showing two different approaches for transconjunctival incisions. One being what is described as a preseptal incision, and the second being postseptal. It has been my experience that it's particularly difficult to stay strictly preseptal from a transconjunctival incision, particularly in a traumatic fracture setting, and that there is frequently fat herniation in this approach. And so many of us don't spend a lot of time trying to be in a preseptal plane through a transconjunctival incision, but I believe there are surgeons who do typically try and do that. Following the periorbital incisions for approach to the orbit and to the orbital floor, perhaps the major workhorse for all of the midface approaches is the vestibular incision, shown in the black line through the left maxillary region here. For those of you who are have any experience at all, you know that you can access a very large area of the midface, and essentially the entire maxilla all the way up to the infraorbital rim, the malar eminence, and the beginning of the zygomatic arch through this incision. We tend to make this incision high enough in the vestibule so that when you close, you have an easy flap to put suture through, and when your patients are edentulous, that sometimes is important because if the patient wears dentures, you want to make sure that the incision is high enough in the vestibule so as not to prevent the patient from being able to wear their denture on that scar following surgery. So we typically say 5 millimeters or more above the attached gingiva. Again, the closure of this incision is important when we talk about our facial approaches. Previously, we emphasized resuspension of soft tissues, fascia, and of fat pads. With the closure of the maxillary vestibular incisions, we know that we are going to get widening of the nasal base, of the alar base, when we use this dissection. So because of that, during closure, we do put an alar suture in to try and re-narrow or reposition the lateral alar bases, or the both ala to decrease the width of the base. It is known that over time that base will widen out again, but trying to reposition it at this closure will help prevent significant widening of that alar base over time. In addition, this incision can cause some flattening of the upper lid, and to try and avoid significant flattening, VY closure of this incision is recommended. We typically will close a centimeter or so of the incision in the straight leg of the Y fashion, and then do a running incision of the remainder of that closure. And typically this closure is done with some kind of a resorbable suture, either chromic gut or vicryl suture. That looks like a question. There's some questions over here that I am failing to look at, sorry. For the alar cinch, I use a long-acting incision. I'm sorry, a long-acting, long-lasting suture, either a monocryl or you can even use Proline in that area to be long-lasting. And Dr. Seth is answering some of those questions. Thank you. So our summary and take-home points. Standard approaches to the midface provide excellent exposure and can leave scars that are fairly inconspicuous. We've reviewed the major approaches to the midface, including the coronal upper and lower eyelid incisions and the vestibular incision. And we've made a point to discuss resuspension of soft tissues and closure in layers. At this point, when we typically in our MFT courses would have a time where we discussed a major area of the face, and then we would go to a small group session to review cases. That small group session is difficult for us to replicate today with everybody who is on the call. However, we're testing out the review of some cases, and so I will just go through one recent case, and we'll go through this case as though we were being interactive between myself, Dr. Seth, and Dr. MacLeod. Are you guys on the call? Can we?
Yes, I hear you perfectly.
So for those in attendance on the webinar, Dr. MacLeod and I will discuss this case as though we would in a small group setting, and Dr. Seth will be manning the questions for us to discuss as they come up. So Dr. MacLeod, if this were your case, you're called in the middle of the night, you've got a CT scan, because everybody gets a CT scan before you get called. I have 3 images that I'll show, and then we'll just discuss what the diagnosis of the patient is and what we might be going through. So we'll show 3 views here. The axial, the coronal, I'll give you a second to review, and then sagittal view. And so I'll go back to the beginning of these. Would you describe to us what you're thinking, what you're seeing, what your thoughts are on how to manage this patient?
Well, what I'm seeing here is an axial image of the patient's mid-face, which shows significant comminution of his zygomatic orbital maxillary complex with significant subcutaneous air. And the mere presence of such an injury on an image like this makes me concerned that this patient is adequately assessed and resuscitated by the trauma team. This is certainly somebody who needs to be managed and resuscitated according to ATLS principles, needs to have his cervical spine immobilized optimally, and needs to be assessed very carefully for other injuries. Looking here, you see some disruption of his orbital floor. You see again significant subcutaneous air, disruption of his zygomatical maxillary and maxillo-nasal buttresses. You can see that he's intubated as well. Again, this is a patient with a significant injury. The presence of the tube makes me concerned that his visual assessment may not have been optimized beforehand. So this is, again, somebody who I think probably needs an ophthalmological assessment early on in the procedure. Interesting here, although the antral buttress wall is significantly displaced, the the orbital floor itself does not appear to be significantly disrupted, although this might be false because he's got posterior displacement of the zygoma, so he might actually have some crushing there.
Excellent point. So based on our CT scan, what fracture do we think what's our diagnosis, and what are we planning for our approaches to expose the fractures?
Well, as I said, I think this guy's got a significant zygomatic and maxillary complex fracture. So in terms of approaches, I think having optimized them and stabilized them, you need to think about how many of those fractures you need to expose. He's going to need, at least in my opinion, a transcutaneous approach to, or transconjunctival approach to the orbital floor. He's going to need a transcutaneous approach to the frontozygomatic suture and a transoral approach to the zygomatic maxillary and maxillo-nasal buttresses that as you demonstrate there.
Yeah, so what incisions do you think you were going to use?
The question is whether he needs a coronal flap as well to assess the zygomatic arch. So in my hands, personally, he would get a right blepharoplasty incision for the upper lid, a subciliary / second crease incision for the orbital floor, infraorbital component, and a transbuccal approach for the zygomatic and maxillary and maxillo-nasal buttresses.
So here I've demonstrated a transconjunctival approach. Because we don't have a whole lot of time today, and there is a question about risks of transcaruncular extension. Do you want to answer that question, Dr. MacLeod?
In my experience, I've had very little problem with the transcaruncular extension if it's done carefully, just going right behind the plica. And I close it minimally with a fast absorbing gut. I think the important thing is making sure that you actually need to go that way in the first place. The main advantage of it is to give you access for the medial component.
I agree. I think we have concerns about the lacrimal apparatus and the potential for getting into the lacrimal lake region and causing scarring and epiphora, but I'll concur with Dr. MacLeod that doesn't seem to be a very common complication of the approach. I
think that just as a parenthetical comment about that, I think rather than calling it a transcaruncular approach, if you call it a postcaruncular approach, that gets you out of trouble because you're heading for the posterior aspect of the lacrimal crest rather than coming too anterior. I think that's where you can get into trouble. So, Dr. MacLeod, then what, in looking at the, severity of this fracture, are there techniques that you are thinking about ahead of time that may help you with the reduction of the bone? It depends on your institutional capacity, but if you have access to intraoperative CT and navigation for a complex fracture like this might help you with your spatial orientation. So I'll show an illustration here. Can you describe what extra stuff is going on here? Well, you have two extra steps with a look at things. The first you have is you've applied a transcutaneous reduction hook. It looks like a Carol Gerard screw, and you've got the navigation instrumentation in place using a fixed landmark on the skull to help orientate yourself for an optimal reduction of the fracture. So we have another question in the Q&A area that says, what are the advantages and disadvantages of transconjunctival versus subciliary approach? You indicated that you might use a subciliary, and I obviously indicated, at least in this case, a preference for transconjunctival. For me personally, transconjunctival closure is a lot quicker. Many people don't close it at all. I typically will put one suture in to cover over a bone plate that I would have placed. I think, from a subciliary approach, the exposure and then the closure, I think, take a little bit longer, and I think I'm more worried about scarring on the external lid than I am scarring from the transconj approach. Do you have thoughts about that, Steve? I do, actually. I've been around since dinosaurs roamed the earth, and they drained the swamps, and was in the advent of the transconjunctival approach when Tessier first described it in the 70s. And interestingly enough, Tessier, Tony Wolff, Paul Manson, and others have ebbed and flowed about their enthusiasm for the transconjunctival approach, because although complications with the transconjunctival approach are quite rare, when you get them, they're more difficult to correct because that entropium is a real difficult thing to fix. And there's a couple of good studies that have been published, and they all consistently show that a middle incision is associated with the lowest rate of entropy or ectropy. And the scarring is pretty acceptable. Even in a young chap like yourself, there's a secondary scar there that you can drop the incision into. So on balance, I prefer for a pure floor or the anterior component of the rim to go for a transcutaneous approach. I do think the transconjunctival approach comes into its own when having to go medially, because you can take into account that transcoroncular, retrocoroncular extension and get down the medial orbital wall.
Very good. We're at 11:30, and I know it's your turn to go, so I'll just show the use of navigation in this. We didn't have mirroring software for this case, but using the navigation wands after the reduction, we get an idea that we are at least close to symmetric with the new position of the malar eminence. And there is a question about how far back you can go, and you want to stop short of, I guess, technically the annulus of Zinn, but typically 35 millimeters is a safe amount posteriorly to go on the orbital floor. And obviously with the use of navigation, we can tell exactly where we were with the posterior plate. I have a couple of pictures showing post-op imaging. And because we are in the day of Corona, this was 2 weeks post-op on a FaceTime telemedicine. So we still have a considerable swelling going on here. But I think with that, Dr. MacLeod, I will stop sharing and I'll turn it over to you.
Thank you, Dr. Cunningham. I appreciate it. Great presentation. I ask people to indulge me as I work on my technical skills here. Aha, it's quicker than I thought. Well, good morning again, everybody. Thank you for joining us. My name's Stephen MacLeod, for those of you who don't know me. I have the good privilege of being the current chair of the AO North American CMF board, and I'd like to welcome everybody to these presentations, and I hope they'll be of benefit to you. Isaac Newton almost certainly went through a similar sort of plague and pestilence in his day and made the observation that if he saw better than others, it's because he stood on the shoulders of giants. And I'd like to thank the giants that I've had the pleasure of working with for the last several years. In particular, shout out to Andy Moore and the California otolaryngologist who gave us this idea for putting together these webinars because they've kind of saturation bombed themselves with courses every night of the week now for several hours. And I think it's a great way of keeping learning alive. So I'd like to thank them personally for that. And thank Andy for his friendship over the years. I'd also like to thank the AO North America staff for making this possible and helping Larry and I negotiate the technical hurdles. So shout out to you all for that. And a big shout out to Raoul Seth, who's come in at the last moment to help us with the moderating and has done such a great job. So thank you to all, and I hope this is a benefit to you. So my remit today is to take us through surgical approaches to the mandible. And what we hope to do is to review the relevant anatomy, reconcile the anatomy and access obtainable through the different types of approach, and troubleshoot potential complications associated with the axis of mandibular fractures. I'd ask you to continue to ask questions through the chat room to Dr. Seth and Dr. Cunningham. And when we come to the small group case at the end, we'll hopefully answer any questions that you have with that. So the anatomy of the mandible is largely based around avoiding things. And the things we're trying to avoid are the facial nerve, which Dr. Cunningham elegantly talked about earlier on, and also the inferior alveolar nerve, which is a major sensory nerve to the lower midface. And then we have these terrible problems called teeth that get in the way of when we're trying to do our good work. We have to try and, in the words of Willie Killer, hit them where they ain't and avoid the tooth roots. So there are many ways to approach the mandible, and they all have pros and cons. As Dr. Cunningham mentioned in his talk, sometimes you can utilize a pre-existing laceration. However, it's important not to use a laceration just because it's there if it doesn't give you the access that you need. And it's sometimes more prudent to close that laceration and go for a more optimal approach. The intraoral approach has a lot to commend it because there's no scar like no scar. There are a number of extraoral approaches available to us, and we'll talk about those as we go through. Moving into the technological realms, there's the ability to use instrumentation to help us work transbuccally, and also for those with particular skills, particularly in our otolaryngology world, the endoscopic approach may have some advantages. Although personally, many times I think it's an operation in search of its indication. So looking at the anterior mandible, This can often be approached optimally sublabally through a transoral incision, as seen here on the left. As Dr. Cunningham mentioned in his presentation, we want to leave ourselves an adequate cuff of gingival tissue for two reasons. One is to give us something optimal to suture to so we have a good seal, but secondly also to make sure that we don't leave ourselves short of tissue and give ourselves scarring and webbing that can give rise to hypermobility. When approaching the anterior mandible, we need to be aware of the mental nerve and the anterior branches of it. And as a simple rule of thumb, be very mindful about not being subperiosteal when you're posterior to the canine. You really should be in a subperiosteal plane at this point to identify the nerve and mobilize it so it can be retracted and not inadvertently sectioned. I'd like to thank Ed Ellis for the illustrations that are here, and also the AO for making these slides available to us. So thank you for them. Sometimes the anterior mandible is most optimally approached through either an existing laceration or a cutaneous incision in the anterior mandible. In this area between the mental foramina extraorally, you're in a relatively safe area with relatively few major nervous structures available to be encountered. This approach has something to commend it if dealing with a complicated fracture, particularly those with considerable obliquity. But most fractures, as I mentioned earlier, can be accomplished transorally in the anterior mandible. The anterior mandible can give you good exposure, as seen here. We can debate until the cows come home the advantages or disadvantages of the forms of fixation used, but the advantage of the transoral approach is it gives you a chance to, in real time, assess the adequacy of the occlusion while carrying out a reduction in a way that the transcutaneous approach doesn't give you at all times. Here again, you can see the amount of retraction that's obtainable right down to the lower border transorally between the mental nerves to enable fixation to be applied optimally in the lines of ideal osteosynthesis as described by Champy. And here's an example of a post-operative result showing the ability to get multiple plates in with avoiding tooth roots below the apices through a transoral approach. Sometimes the transcutaneous approach is necessary, often because of complicated fractures or misadventures. Here we see a gentleman who'd had attempted an intraoral repair using osteosynthesis wires, who came back with problems. And here you can see the inadequacy of fixation through the transoral approach. And in his case, the ability to go transcutaneously between the mental nerves gave us an opportunity to apply real rigid fixation, functionally stable fixation, and provided an environment for where bone grafting could be considered. Moving posteriorly in the mandible, the intraoral approach and the extraoral approach begin to overlap. And the intraoral approach is surprisingly versatile in the posterior mandible with extension and the modern instrumentation such as the transbuccal trocar shown on the right here. The posterior mandible in the area of the angle and ramus can be approached transorally, can be very useful for the application of angled plates, again, along Champy's line of ideal osteosynthesis. Again, in this area, if you have to go laterally, transbuccal instrumentation can be helpful and provide you with relatively good access, relatively good instrumentation technique at minimal risk to the facial or sensory nerves. Here's an example of one where there's been considerable exposure of the mandible, basically pretty much from angle to angle, with skeletonization of the mental nerves, allowing the placement of rigid fixation really quite far posteriorly, almost back as far as the angle of the mandible through a transcutaneous, transoral approach. And the key take-home message here is once you're subperiosteal and identify the nerve, you can really work to skeletonize it, and that'll give you much more attraction possibilities than you might otherwise think possible. Note also here the use of the reduction forceps transorally with the patient in occlusion to ensure that you've got control of the occlusion and adequate reduction simultaneously. Moving extraorally in the angle of the mandible and the body of the mandible, the key structures to be avoided here are the facial nerve mandibular and to a lesser extent the cervical branch, although the cervical branch is often sacrificed without noticeable loss of function to the patient. Again, as shown as on the left here, excuse me, on the right here, quite considerable access can be obtained through a single incision here. In classic teaching is to incise 2 finger breadths below the lower border of the mandible to avoid damage to the marginal mandibular nerve. Thinking about the condyle, there are a number of ways to approach the condyle extraorally and also, for that matter, transorally. Dr. Cunningham talked in his talk about the extension preauricularly of the coronal flap down to expose the zygomatic arch, which it certainly does, but can also be a friend to you for approaching the condyle and for the high condylar fracture involving the condylar head or condylar neck. Involving the lower part of the condyle, you can think about going either transparotid or retromandibular, which are basically variations of the same theme. And the significant point here is to avoid damage to the facial nerve as it emerges. The classic teaching from Digman and Grab back in the 60s, even before I was born, is that the marginal mandibular branches are anterior to the, are above the facial artery when they are anterior to the facial artery and below the facial artery when below. So again, if you can identify your facial artery and vein through your transcutaneous incision as you go down, you have the ability to take the flap up safely, preserving the facial nerve with you. And that subcapsular dissection has a lot to commend it. As you can see here, in most cases, the marginal mandibular branch will be above the lower border of the mandible, but again, in 20%, which is a significant percentage, it can dip down a little bit. So that 2 finger breadth margin of error is not something to be sniffed at. Thinking about the transparotid approach or the retromandibular approach, the key things here to remember are that you must make sure the patient's not paralyzed so that you can look for any twitching of the marginal mandibular cervical branches or buccal branches if you're doing a pure transparotid technique here. And you aim to take your dissection between the cervical facial and temporal facial trunks of the 7th nerve as you go towards the mandible. We can talk later, perhaps during the discussion, the advantages and disadvantages of using nerve monitoring for this. I'd be interested to hear what Dr. Cunningham's approach is to that. A technical point when coming out from any of the retromandibular or transparotid incisions is to make sure that you ensure that you do close over the parotid capsule and SMAS layer, as this can be important in helping to prevent the accumulation of a sialocele, which, although treatable, is often irritant to the patient. Sometimes you have to put everything together, and this is an example of a guy who came through our clinic several months ago who had been shot years previously and had a ankylosis of his condyle, which he wanted treated. The ability to use transoral, transcutaneous, and preauricular incisions enabled us to carry out a resection of his ankylodic mass. And then the addition of his infraorbital lower border incision enabled the ability to place an implant and reconstruct him with an alloplastic joint and giving him return to function. So sometimes the ability to use all these approaches has to be part of your armamentarium. We talked about the endoscopic assist. As I say, in many cases, it's a technique looking for an indication. It's very technical dependent, it's very assistant dependent. As I say, I think often our colleagues who are regularly using endoscopic instruments are the best place to utilize these to their advantage. That said, they can be of some utility. A couple of teaching points with the transbuccal endoscopic approach is that you often suffer from this parallax error. As you see in the top slide, it looks like you're perfectly aligned on the posterior border. You've got a good reduction. But if you look at the bottom slide on the left, on the right postoperatively, you'll see that those lowest screws are actually further forward to the angle than you think they are at the time of placement. So you must be aware of this ability to have a parallax error. Those of you old enough to remember SLR cameras and the like will remember that you can be sometimes too close to get an accurate focus. And that's really what happens here with the endoscopic approach. So to summarize, it's all about anatomy and being able to go where things aren't. There are a number of approaches, as we've talked about, and the access that you need is related to the area and type of fixation you've required. So I'd like to stop there and move on to some questions, if there are any, and then a small group discussion.
Steve, there is one question here, and I'll read it out loud. Maybe you want to address it. In cases with unilateral subcondylar fracture management with MMF and a contralateral simple angle fracture, will the angle fracture require a lower border plate in addition to the external oblique ridge tension band?
I think it really depends on how you're managing the condyle fracture. If you're managing the condyle fracture open, you can actually get relatively solid fixation on the condyle fracture. And then I think you can use a Champy-style technique on the angle fracture. And Ellis has talked about that you need to have heavier fixation in one area when you have multiple fractures. If you're trying to manage the patient gently with elastics, you may need some extra help on the angle fracture to give you support. And if you're managing it non-operatively on the condyle, I think that certainly mandates something more rigid, perhaps even an extra roll approach to the angle fracture, unless you have a really good citizen such as yourself with the injury.
Thank you.
So if there's no other questions for the time being, let's look at a case and see if it generates some conversation for us.
Steve, if I could just state two more questions for Brenda and or Julie to address at the end. Somebody wants to know, we want to make sure we tell them how to get the recording again at the end. And then someone else wants to know how they can get an AO t-shirt. All right, go ahead, Steve.
So let's look at this lady. This is an 87-year-old lady in Hamilton of a nursing home who unfortunately fell on her face when she slipped in the nursing home and was brought to the emergency room where she was diagnosed as having basically undisplaced fractures of her mandible. And it was thought that because she was relatively old, relatively fragile, and a little bit demented, that she would be best managed non-operatively. And this is her appearance about 10 days later. And thinking about her at this point in time, are there any considerations that you would have about her management, just in general?
Well, you know, certainly the age group is one that we know that if we do any significant surgery, we increase their risk of a cardiac event. And so I think that the original assumption that maybe we should wait and see if something can be done close is very reasonable in a person who's of advanced age with other comorbidities. You get the, you know, look at her face and you see all the ecchymosis and the swelling here in the midface, and you wonder, wow, something must be, you know, really wrong in the midface. But of course, we know that in this age group, particularly in patients who might be on aspirin or another anticoagulant, the bruising can be much worse than the actual image of the fracture on scan. So I am worried about the patient's comorbidities, but I would proceed to looking at the scans, look at the x-rays, and seeing if we sort of agree with that assessment.
So if we look at the top x-ray, this was the initial x-ray that she had upon presentation to the emergency room 12 days earlier. And you can see here her injuries. And then you can see underneath the Panorex that was taken 12 days following her injury. So would you like to speak to what's happened here, perhaps, Larry?
Well, we have sort of this, pencil thin mandible with a bilateral body fracture that is unfortunately not an uncommon fracture pattern in the aged patients. So immediately I begin to think of for a reconstruction of this, it can't be something that's with small plates. It's going to have to be with a larger reconstruction plate. We would talk about approaches, but I think to really get a single plate that goes angle to angle and to be as careful around the intra-alveolar nerve as we can, I would be thinking of an extra-oral approach. The nerve is going to be laying on the top of this mandible because of alveolar ridge resorption. So those are things that I'm thinking about. I mean, there are a couple of papers out there about bone grafting primarily in a case like this versus the use of bone morphogenic protein or potentially both to try and get this bone stock to heal in a patient who may be osteopenic or osteoporotic.
So talk to me, if you could, for a minute, Larry. Why did this happen? This is a delicate old lady who basically it's nothing stronger than yogurt. How did you manage to displace so significantly over a 10-day period?
Well, you got fractures here, and I think, biologically, the beginning of the healing of the fracture is for osteoclastic activity to start cleaning the fracture segments and actually having bone resorbed away more. And so I think, this is sort of a normal time period that would begin to happen. And instead of the initial healing, she actually didn't form callus in this area at all yet. So
I think that's absolutely right, and I think it's compounded by the fact that the depressors and elevators of the mandible generate forces not to be underestimated, and you have the situation where those depressors anteriorly, particularly the genial muscles, can pull things downwards and then have an unopposed action against the medial pterygoids posteriorly and give this bucket handle. And in this more acutely injured patient, this is one of the few areas where a mandible fracture can give rise to airway obstruction. It also brings me to a point I neglected to mention earlier. Anteriorly in the mandible, the mentalis muscles are forced to be reckoned with, and resuspension of the mentalis muscle is really quite important when you're using anterior mandibular approaches. So I apologize for not mentioning that now, but remind myself remembering it later.
So Steve, we have a question I think is apropos to where we are in this case presentation, and the question is, when would you consider external fixator in a patient like this?
I think if you have somebody who's very, very delicate, and you may be time barred for her life expectancy, I think a next fix for pain control is reasonable. I think if you have somebody who has any sort of performance status, that realistically asking that mandible to heal just with the next fixator is a big ask, because the fixation is not rigid enough and the osteopenia is sufficient that you're never going to get a good union. So I think I would use it for temporization and pain control, although in those cases it can be very useful.
Yeah. Agreed. Yeah.
We have a somewhat similar question of the advantage of using circummandibular wiring with existing denture at the first presentation.
I think Brian Albert summed it up best. Old people don't tolerate maxillomandibular facial very well. They tend to die. I think it's important to realize there was work done nearly 30 years ago now by John Kaywood and John Williams that showed the simple act of putting your teeth together decreases your vital capacity by 25%. And for a young man like Larry or yourself, and even for an older guy like me, I can survive with a 25% diminution of my VC. But if you're a little old lady with a little bit of COPD, that's enough to tip you over the edge into respiratory failure. So I think really avoiding circummandibular wires, if at all possible, is something to be commended.
We have a few other questions.
We have a secret panelist on the webinar with us, Dr. Van Sickles. Wants us to make sure that we talk about the need for nutrition in these patients and the way that it's much easier to get good nutrition when we don't have an external fixator on and when we've got rigid fixation. So
I think that's an excellent point, and I think unfortunately in the trauma services generally, it's often something we neglect at our detriment. So I would absolutely agree with Joe and say that nutrition is king for this, because we want to optimize people's performance status, and that's really the cornerstone of it. And just parenthetically, as we deal through the COVID epidemic, we're realizing there for the post-viremic patient that optimal nutrition is really very important.
Steve, another question is, Dr. Ellis is actually also online with us, and he asked, what's the best surgical approach to bilateral atrophic mandibular fractures? Well,
he's kind of stolen my thunder, because that was going to be my question for you. How would you approach this?
I would do a transcervical.
Would you do a single incision, or would you do bilateral incisions?
One incision.
Something like this, perhaps?
Yes, sir.
So talk to me what you think the advantages of doing it this way are.
Well, this incision allows, as you're just showing in this photograph, exposure angle to angle all the way around the mandible and protection of the infraocular nerve superiorly. You could do, I guess the question is, do you do bilateral submandibular incisions? And I think, I think most of us would agree that a single plate here for this particular fracture and the bone grafting that you have shown in this illustration is easier done through the sort of what we call apron incision, and the closure isn't really that much longer. I think it looks like in your image here that you have gone subperiosteal on this mandible, which is a question I think of, that's a topic that's discussed sometimes. Should that dissection be supraperiosteal to maintain a blood supply to the mandible, to the atrophic mandible? I typically go subperiosteal, as it appears that you have here, to put a bone plate on, but that's
so that goes back to the work of John Bradley back in the 70s that showed that you get centrifugal atrophy of the inferior alveolar artery with age, and made the observation that the blood supply of the periosteum became more crucial to supplying the blood supply to the healing mandible fracture. But it must be remembered that that was also back in the days of nothing other than pin fixation or MMF or circummandibular wires for the management of it. I think with the advent of modern fixation systems and the ability to graft, that that becomes less crucial an issue, and often makes an anatomically difficult operation even more difficult.
So I have a couple of questions, or I'll answer to everybody that after the meeting, participants are going to receive an email that's got a Zoom link to the recorded session. And the shirt that Dr. MacLeod is wearing is older. Brenda said it, not me, that you're wearing an old shirt. And I don't think we can get that shirt anymore. So to some of the older, some of the previous questions. We have 4 minutes left. Dr. MacLeod, do you want to go ahead and finish this case, and then we'll...
Sure. So this is the lady's post-operative panorex, and I'm grateful to my friend and colleague George Kushner for the image. What you can see here is that she has a reconstruction plate that's slightly bigger than a native mandible is. And in follow-up, the question became, what can we do to dentally rehabilitate her, if anything? So what are your thoughts about dental rehabilitation of the atrophic edentulous mandible, Larry?
Yeah, so with dental implant reconstruction, I think it is possible. It depends, obviously, for everybody who does dental implants, you have to have enough bone height and width. And so if, as you have illustrated in this case, you've got adequate bone grafting that would allow, you know, at least 5 or 6 millimeters of width to be able to get 2 implants in for an overdenture, as well as a height. And I think most of us would want at least, if you could get it, 8 to 10 millimeters of height in the front for a good length. Obviously, there are shorter implants out there that could be used depending on the patient's wishes, health status, and other needs.
We've actually had that a good experience with doing exactly as you described. Surprisingly, you can sometimes find that in these circumstances, patients will actually tolerate a conventional denture with a soft lining, which I know seems counterintuitive, but it's amazing what human beings can adapt to. So again, I think the ability to get the mandible accurately and rigidly fixed does provide you with many more reconstructive options dentally than the use of external pin fixation or circummandibular wiring does.
Agreed. So, Dr. Seth, do you have any final comments for us or things that we need to review?
We have a couple of questions that just in the last couple of minutes, I want to make sure that we get people some answers. One question is, what would you say is the minimum mandibular height you would need to use for an atrophic mandible?
I don't think there is a minimum height. I think as you maybe don't see as accurately as I would like on this one because it's a lateral projection rather than a panorex, you find that there's bone preservation where there's muscle. So in the angles over the pterygoid region and the masseter region, and anteriorly where you have the confluence of the digastrics and the genial muscles and the mentalis muscle, there's relative maintenance of bone height. So if you use those areas and maintain bone height for your fixation, you know, the mandible can be smaller than the plate and the saddle areas with virtual impunity, because you're not going to try and drill your screws there for 2 reasons. One is the bone's very brittle and tends to fragment like a teacup handle. And the second is the nerve there is riding through the mandible there as well. And if you put any fixation where the nerve is, you're going to certainly render this patient even more numb than they might already be.
Great. We have a couple of questions regarding bone grafting. Would there be just if you could just sum up maybe your thought process on bone grafting in atrophic mandible fractures?
If you think you need it, you should do it. It's a bit like a tracheostomy for an ENT surgeon. If you think about a tracheostomy, that probably means you should be doing it.
There was one question about the source of the bone graft. Any thoughts of the source where you'd harvest?
I'll let Larry go first.
I tend to do iliac crest just because it's a very common for me and sort of the workhorse. You could use tibial bone graft, I think, if you wanted to do that as well. For somebody of this age, I probably would not go to a lower extremity just because ambulation in this age group is pretty important, and I feel like a limited incision at the iliac crest I feel like would limit mobility less, but I'm open to conversation on that.
I would ebb and flow with that one. I think, you know, Dr. Cunningham's points are well founded that, you know, people who aren't ambulating well, if you give them a reason not to ambulate well, will take it and be less mobile. I'm not sure that there's, in the older population, there's much of an advantage in going for the hip rather than the tibia in terms of ambulation, but I think you can take that in individual merits. The other historic technique for the atrophic mandibular fracture to mention, in some ways, in large measure, to appreciate in contemporary practice, is the use of ribs. There are a number of techniques described in the 70s where you would take a rib, split it, and apply it over the fracture sites almost with the circummandibular with bone plates to provide bone grafting and fixation simultaneously. I think in terms of the hit you take on your ventilatory mechanics, you know, harvesting ribs is probably best avoided in this population.
Great.
Very good. Well, it's 12 o'clock. So Dr. Seth, any other final comments?
Not for me. I want to make sure we stay on time for all of our audience members. There may be one or two questions that we may have not gotten to. Apologize about that, but these are really big topics, and one of the big reasons why we have quite a few sessions outlined during this time period. And so the complexities we hope to hash out with you as time comes.
Well, thank you to everybody. Stay well, stay safe, and stay in touch.
Very good. Thanks, everyone.
Thanks a lot.
You'll get an email with the address to go and see the recording. And please watch out for the email blasts for the coming topics in the next few weeks.
And
Thanks
thank
very
you
much.
to Oreo staff.
Yeah.